morning.
Good morning. How are you?
All right, and yourself?
Look at you, all spiffy. I feel like you done dressed up just for the occasion. Look at all professional and stuff on a Saturday morning while we spilling this Saturday morning tea. Look, I feel like I done lost my voice. I've been screaming and hollering. Oh my God. I am, let me just say, exhausted. Exhausted. It's been a long, long week, but a great week. A great week. How has your week been?
It's been good.
Okay, I'm like you. I hear all kinds of feedback. Hold on. I'm hearing you in different places. Okay, say something.
It's been good.
This computer. Okay. Okay.
Want me to say something else?
You good. You good.
Oh, okay. Yeah.
I was hearing you from my computer speakers and over here in these speakers, and I'm like, wait, I hear a double echo, but we're good. Good. Oh my God. I'm so excited about today's show. For a couple of reasons. Especially when we start talking about AHiMA. So I'm trying to determine like which way I want to go first. Do I want to do AHiMA first? Do I want to do the other first? But let me start with the introduction. Let me just start at the beginning like I'm supposed to. How about that? See what happens when I get all excited and get all off of target and what I'm supposed to be doing. So welcome everybody to our Saturday morning tea, where we discuss health information, news, education, certification tips, entrepreneurial tips, you name it, we probably will discuss it in some form or fashion as it relates to our profession in health information. I am Clarice Warner. I am the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And let me just ask you this question first and foremost. Do you know what it takes to be a certified marketable medical coder? Do you know? Well, before I introduce my co-host, let me share with you information on a free email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right. So if you are joining us, and hello, good morning, everybody from our Clubhouse family. Welcome and hello to everybody from YouTube, Facebook, and our new friends over there on LinkedIn. So welcome everybody and joining us. So if you're interested in the information on the 5 steps to become a certified marketable medical coder, you can check out the link that's in the Clubhouse. If you are on YouTube, LinkedIn, or Facebook, you can check out the link in the description box for more information. And we will be glad to share that information with you. So. Today, I need to introduce my wonderful, illustrious, always consistent, always on time, there in a pinch, my sounding board, all of the things. Mr. Jesse, the registered trademark, the coding nurse. So, sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I've been in LPN for a good number of years. I switched over into medical coding in 2014. And during the pandemic, I created the Coding Nurse LLC, where I help other nurses and other people with clinical healthcare experience transition into the world of AHiM.
Yay. And we're so glad. And I'm sure they are so glad.
Can't hear you.
Oh, I forgot.
Okay.
Look, they hear me on the other platforms. You don't hear me in Clubhouse. And I'm glad. And I'm sure the other nurses in the profession who are transitioning over to the wonderful world of health information also are glad that you are here in this space and assisting them in that transition. Even though I side eye you every day, but I'm glad that you are part of the family and um, spilling the tea, all the tea on what is happening in our profession. So let's get this cracking. So I guess I will start with AHiMA. So last week, that's why I'm so tired. Oh, before I do that, see, can you tell I'm rusty because I haven't done this in a week? If you are on Clubhouse and you want to join in and add to the conversation, please just raise your hand. We are monitoring the comments and monitoring the room. And if you have something you want to say, don't be shy. Raise your hand. We'll put you up on the stage and we will let you join in on the conversation. Remember, your opinion matters here and it's welcomed here. We love to hear from the folks who join us because there are various different perspectives and vantage points. And we want to hear from you. So come on over, let us know what's going on. Also, for my Facebook and YouTube, and I believe LinkedIn friends, while LinkedIn, you can't see anything that I push to you, but we can see any comments that you make. So feel free to join in the conversation using the comments, and we will definitely get you in and get you on. Okay. So today, for those who are joining us, we have two topics today. We're going to look and talk about the whole buzz, and it turned into a whole buzz. A whole buzz on CDI queries, and we're gonna talk a little bit, or I'll do a little quick debrief, I guess, if you will, on AHiMA 22. So let's start with that. So with AHiMA 22, let me just first of all say, um, it was great to be in the space. It was great to be in person. And I got to meet so many wonderful, wonderful people. Let me just first shout out Miss Barbara from South Dakota. Now, let me just tell you, when I told her I did not know that there were Black people that lived in South Dakota, and she told me she probably was the only one. It was amazing. We had a great time catching up and just fellowshipping and talking about our profession. It was really a good time. I met um some folks that I've like followed from afar for years, and they were great people. I volunteered, so it afforded me the opportunity to meet even more people that I probably wouldn't necessarily have met or talked to, in a session, because of course you're paying attention to the person that is presenting. But it allowed me to kind of meet and greet and just holler at folks and take pictures. Y'all know I take pictures of everything and take pictures and all the things. And so I was also glad to see everybody in my state, the state of Columbus. Now, Columbus is the state of Ohio. Columbus is not my city. I live in Cincinnati, but it's only a couple hours up the road, and just had a good time. Columbus owes me nothing. I love Columbus. Columbus is fun. There's so many diverse things to do in Columbus, and we were right there. I felt like we were right there in the thick of things, in the convention center. So it was fun time had by all. At least I had a great time. I hope those who went had a great time as well. Let me get rid of this banner. So let me give you some business here first and foremost, because there is some business that happened. Um, yes, definitely. Definitely. Okay, so let me let you know that hey Lashanta, hey Synovia, and good morning, Tasha. I'm reaching out to the NKK. I'm sorry, I didn't. He has an echo. Sound.
I got took care of it.
Okay. Oh, it was you, not me. Oh, look at God. Okay. Let me just put everybody out there. Okay, so let's get to some business. Some things that I'll probably talk a little bit more about as the weeks go on. But the big drop that I had heard that made me like stop, like what is that? AHiMA is going to virtual proctoring. They're going to start virtual proctoring of all of their examinations. There will be no more testing centers. They have already piloted this for the last several months, and they didn't give a date, but I believe that it will be rolling out the first of the year. So that was really, really interesting. A lot of people, clapped and was excited about that. And I thought about, there are only so many testing centers available. And so sometimes people have to drive far, depending on where they live. They have to drive a far distance to get to those testing centers in order to take those tests. So the virtual proctoring may be a godsend for them. The other side of me, and I'll let you chime in on this, thinks about some of the things we've heard as it relates to virtual proctoring from the AAPC and some of those experiences. And I'm not certain that they didn't release the vendor, or I hadn't heard anything about who the vendor is for them, but hopefully they've ironed out any kinks, because we all know, there are kinks that happen. Look at our show. We all know there are kinks that happen, but hopefully they've ironed out those kinks. And I'm thinking the technology used kind of with monitoring the work from home folks, maybe there's some type of monitoring or some type of technology that could be used with that. I know the AAPC had a situation where you had to have like multiple cameras so they can see behind you, see in front of you, see all kinds of things. I don't know what AHiMA has put in place for that, but hopefully it's a little simpler. You don't have to. And one of the things that people were talking about, I know from the AAPC perspective, was the additional cost that they had to fork out, because they had to go purchase like the cameras for the back, and you would have I don't even think you can use your camera on the computer. You actually had to have a standalone camera, where you had to put it somewhere so they can see the whole desktop. So don't know any details, but I thought that was huge. Did you want to weigh in? Let me mute so you can speak.
I think that it's interesting. I think that, they want to remain competitive, because if you have another certification vendor or credentialing vendor where people can test from home, it's just common sense that you would at least offer that. But I'm just curious. So they're not going to have any more testing centers at all, because I'm just thinking there are a lot of places where internet reception is really not that great in this country. And if you don't have a certain speed, that's going to definitely cause a lag or some kind of, cutoff of your test. You might have to restart. So, I mean, I'm sure they've done their homework, and I'm sure they have identified any kind of areas of opportunity that they have to work out beforehand, but it'll just be interesting to see.
You're absolutely right. And that is something to consider, because we know in rural areas they don't, well, not in some urban areas, forget rural areas. I know sometimes you riding down the street and all of a sudden everything drops. There's like pockets where service drops. So yeah, hopefully they'll figure that out. Again, they haven't rolled out any specifics. They just let us know it was kind of like the peek to the future, if you will, letting us know that that's coming down the pike. One of the trends that they talked about, and we've already discussed this here. So I was like, well, we ahead of the game. We've already had these conversations. Of course, they're talking data analytics. That is huge, huge, huge. for us, they actually coined it the new medicine. Like, okay. So just making sure you are on point with all of the technology that is coming out. Being in front, especially if that's your jam, being in front of that and getting the necessary certifications. They talked about getting, and I think we've talked about it too, places where you can get free certifications for different types of software. I was told about Python. Python and healthcare, there's some kind of link. Coding, learning information through Python helps you if you're interested in that data analytics, or not even the data analytics space, but the healthcare coding, not medical coding that we do, but the computer IT coding. There's some sort of connection there, and there are all kinds of places where you can get some certification on that. So that was something that they wanted to that was mentioned. The other thing is that's my jam, regulations and compliance. Folks just can't kind of bury their head in the sand. You got to be on top of, which is why I share the way I share, because you need to know, as I always say, you need to know the why behind what is going on. It's huge, and we're seeing it all the time with the different cases that are coming out from the Office of Inspector General, of the Department of Justice, all of those cases where, someone has gone in and done some auditing. They've told you this is the regulation. This is what it is. This is the expectation. This is what it is that you need to do, what you need to know. And then we're going to kind of look and see whether you're doing that. If you're not doing that, Houston, we may have some problems. And so it's real important. Research and knowledge will always be important for folks in our field. We always talk about that lifelong learning. It is no joke. It is basically what we have to do. Another thing, AHiMA officially got recognized as a STEM program. There is a STEM guide that is published that goes to they say grade school, high schools, and colleges. AHiMA is listed in that guide. So we are an official STEM recognized program. They're looking to kind of do some things in that space, particularly on the education side. So making sure that there is practice-based learning, because right now there is a lack of that. You don't have that. You have the theory, you have the book-based learning, but things are moving and shaking so fast. Unfortunately, in the education space, sometimes it doesn't catch up with what's happening in the industry, and they want to make sure that they are doing that. The other big thing is that they are going to start offering micro credentials. Yes. And one of the micro credentials will be around release of information. So if you are a release of information professional in our sphere, a micro credential will be coming for you in the near future. So they didn't release all of them, but someone had a question about release of information. We had a whole open in the House of Delegates meeting. We had a whole open session dialogue because we finished our business early, and it went down in the session. There was a lot of stuff to be discussed in that session. And again, they mentioned those micro credentials, and that release of information would be one of them. They were also talking that, accountability, mission, collaboration, those were the big buzzwords, being inclusive, integrity, and being bold. One thing that stuck with me, and somebody said, and I was like, that is absolutely correct. What gets measured, and I think Dr. Wailisa said this, what gets measured gets done. And I thought about it like, that is absolutely right. Because if somebody is measuring and looking and whatever, then folks don't make sure that those types of projects get done. Of course, I'll kind of segue into CDI because AHiMA released their CDI, the updated CDI query practice brief, if you will. But so they talked a little bit about that too. So I'll mute so you can chime in on any of the things that I've just been rattling off that happened at the AHiMA 22.
I think that it's great that they had this because we have had plenty of conversations here on Saturdays about what is AHiMA doing to promote the industry, and there are a lot of things that we talk about that I'm glad to hear that they have addressed. Um, when you were talking about data analytics, I mean, I really wished I liked it way more than I actually do because I saw the potential for data analytics like 2 years ago, but it's just that's not for me. But for anybody, it is. You will have a job for the next 50 years. It's just amazing what you can do with that knowledge, and also what is interesting is did they mention anything about healthcare cybersecurity?
Yes, and there were several sessions. Of course, I couldn't attend them all. It was just little bitty old me. But yes, there were several sessions talking about cybersecurity, talking about uh, a whole bunch of the standards, being in front of that. They didn't talk credentials per se. So I don't know if maybe there's a micro credential in that space coming up. They didn't say. Again, they didn't drop any gems except for release of information because somebody specifically kind of asked about that. But yes, the security piece was a big thing. They also talked the information blocking, and I know I posted somewhere that they have released the Digital Independence Day, where patients are now able to receive their records digitally. No questions asked. So all the barriers, and here's your favorite, gatekeeping that happens. All the gatekeeping that happens has now gone. If you want to get copies and information out of your clinical record, I'm sure there's still some buzz around that. I didn't see any additional stuff happening because the query stuff, like I said, it took over everything, and we'll we'll let you jump in on that because I know that's your jam, the whole CDI world. But yeah, they did talk about security. They talked about having the standards and putting together. There's a Sequoia project. They talked about that. They actually had people who are involved in the Sequoia project, and that's related to the information blocking and all the operations in health information. Also putting together an alliance to talk about the standards and public policy that supports the end user. So like those of us who need to get additional information, understanding the information that we're getting, and making sure that people were talking about like Epic, and Epic has sort of prided itself on being connected to all the users. So if you're an Epic user, you should be able to reach out, talk to, and connect to any other organization or facility that's also an Epic user if they turn on that feature. And so, but everybody should be in the same boat. Everybody should have that opportunity to have their information sent. And sometimes what stops it is that there are no standards in the data that's being collected. And so they want to kind of erase that, eliminate that, and make sure that those standards are put in play.
That's it. I think this first got started with Blue Cross Blue Shields. They had something called the blue button, and I think that it was about exchanging healthcare information or being able to access healthcare information anywhere for anybody in their network. And Epic, I've worked places where, like you said, if they have the plugin for Epic, you can review or retrieve records from anywhere where it's stored in Epic in any facility. So, and I have, it is really helpful because when you're doing chart review, I mean, I don't know who requests records, but sometimes it's very, very lacking. You have to really go and hunt for records on your own.
Yeah, I agree. Let's see, one more thing. So this was the 76th House of Delegates meeting that we went into. And while AHiMA's still strong, and they talked about, you know, being stronger together and all of those things, I want to make sure folks do understand that they did lose some money. They lost a lot of money, and probably because they lost membership. You know, people have options, and we've talked about that here. You know, folks have options in other spaces that cater to a specialty that they may be involved in, like we talked about CDI and access. Am I saying it right? You know, okay. That they may feel the folks advocate more for them. And I think I asked the question about folks not feeling like their credential matters. And you have people who actually have gone through HIM programs and just, they don't even test afterwards. And because they don't see the value in the credential, they don't see how that credential helps. Oh, that was another thing. They're really, really, really about to do a whole push and partnership with the Society of Human Resource Managers. I think that's what it's called. To really get them to understand what health information is all about, and really learning and providing information about competency and skills versus job titles. They did their own kind of internal review and looked at some jobs that were posted and looked at what, you know, what the qualifications were, as well as what the jobs would entail, and compared them to the skill level of and competency levels that folks from AHiMA who are credentialed and or have gone through the training, this is what you're walking away with. And it matches a lot of those things, but the job title, folks like, I don't know what that job means. And unless you kind of do that breakdown to compare, oh, I can do that. Because I always tell people, just if you see the majority of the things that you can do, apply for the job. I mean, all they can tell you is no. That's all they can tell you is no. But you have an opportunity to talk to somebody, especially if you get to the interview part of it. You have an opportunity to talk to somebody to even get further knowledge and information about a particular position that they may have, because that job title may be in other areas, and it's like, oh, this is what that means. I can do that. We can do that. That's something that, you know, we were trained to do. Oh, we had a field day, and I said, oh, that was the last thing, but this will be the last thing for real. We had a field day talking about clinical knowledge. And, you know, they wanted everybody to stop saying that we don't have clinical knowledge. There were instructors there who said, I teach pathophysiology, not only to health information professionals, but in the same room are nurses, are other healthcare technical folk. I mean, so you're learning this, we are all learning the same clinical information at the same time with each other. So you may have more clinical practice skills, but we all have clinical knowledge. And so, you know, they were like, just stop that right now. Everybody just stop saying that. and get into the habit of explaining that and telling others we too have clinical knowledge. So that I think that was because we talked about the little nursing influx and other influx. Not you, Mr. Jesse, of course, you're one of us. But the new influx based from the great resignation and the quiet. I read about quiet quitting and quiet firing. That was interesting. I read a whole article about what's called now quiet firing, but how you got other people coming into our profession who folks may feel because they're an RN or there's some sort of clinical title that they are more clinically trained than we are, and that just was not the case. And folks it was like a whole rah about that. I'll mute so you can speak.
That was a mouthful. And I just think that's why I always say, when I do my introduction, I always say I help people with clinical experience, because like you said, you know, I have been beating this drum ever since we've been on Clubhouse about this whole, you know, especially when it comes to CDI. And truthfully, I am a real nurse, but I'm an LPN. So in the grand scheme of things, I'm considered the help. I don't get factored in with the RNs. So I'm in the same boat as everybody else. So I just think that the industry, I think that it's great that they are going to partner, because those people like this Society of Human Resources, like you see them everywhere. You see those SHRM credentials everywhere. And I have always seen ads where I'm like, nobody in the coding department had anything to do with this ad, because what they're asking has nothing to do with coding. Like, you'll see risk adjustment jobs where you have to have a CRC, but then they say you have to know ICD-10. I mean, CPT. You do not need to know CPT to do risk adjustment, because everything gets billed. So you can have the biller put that E&M code on the end before they submit it, because that's where they do it. You don't have to know CPT or HCPCS to work in risk adjustment. I have never done traditional risk adjustment and had to put in a CPT code ever. The first time I ever had to put in a CPT code in risk adjustment was when I did CDI outpatient. That was the only time.
Mm-hmm.
But I think that it's great that AHiMA is really starting to step up, and I think that they need to use their status as one of the 4 cooperating parties to really, really make some moves in the industry, because it really is kind of getting away from them. Like, they really need to, you know, show improve.
Well, they had a whole show. I will say that there was a whole show, and it was beautiful. And you know, I'll drop more things in upcoming videos that I think that you should know. So, you know, be on the lookout for those types of things coming down the pike. So let's get into this.
One more thing.
Go ahead.
Speaking of, I am starting a job on Tuesday. It's CDI.
Whoa. Sir, I thought you started a job last week. No. Is this the same job?
Yeah.
Okay.
It starts
I'm like, wait a minute, did you jump ship, sir? Okay.
No. It's just I got the offer way earlier.
Okay.
But it's because of processing and all that. I don't start till the 18th.
Okay.
Now, it is a CDI position.
Okay.
But my title is RN Clinical Documentation Improvement Specialist, even though I'm not an RN. But the position requires you to be either an RN or an LPN. Wow. But they will not take RN off the job title.
So in that position, they only want nursing professionals who can code, I guess, or who have coding background.
Well, no. They even train.
But you got to come in with a license.
You have to be at least a clinical license, yes. It's just they hired me because I had experience. So they wanted to bring in people of, I guess, some people who knew, and then because they're expanding, so they wanted some people who could hit the ground running, and some people they needed to develop.
Interesting.
And they even pay for them to, they train and pay for them to take the CCDS.
Wow. Interesting. Interesting. So how's it going so far? I mean, because I know you still in this process, so
I will know. The first day is Tuesday.
Okay. I know you, sir. You be like, absolutely not. Nobody is playing with you in what's happening in this world. Well, congratulations again. So
we'll see.
Yeah, sir.
No, thank you.
Oh goodness. Okay, so I start seeing so as I mentioned, AHiMA released their update to the guidelines for achieving a compliant query. And this was done in collaboration with the Association of Clinical Documentation Integrity Specialists, or ACTIS. I think I'm saying that correctly. So they've been getting together. Now, AHiMA is one of the cooperating parties for ICD-10, CM, and PCS. And so, they have been deemed kind of the folks who put out a lot of the industry standards. So something happened. I listened to, and I was unable to listen because I was actually in session. But something happened on Talk 10 Tuesdays, which is it's a podcast from the ICD-10 monitor that gives like information, and they write articles and stuff too. And I usually look to some of the topics that they talk about and kind of do a deeper dive on some things. But they have folks from different vantage points. So there's a lot of compliance stuff, and that's primarily the lens that I'm looking for or through when I'm listening to their things. There is a physician that I actually met and worked with at our AHiMA convention. There is physicians and there are attorneys as well. And so they all kind of give, and recently they've added, folks in the health information space, if they are CDIs or coders, et cetera, depending on what the topic is. And so this came out, and I guess there was some kind of question about the queries and what's considered a leading query, and are they prohibited by law? And it was like a whole big, like there are like 3 huge articles, and I'll put them in the. Please let them include outpatient CDI material. Outpatient CDI is really a thing. Correct. You are absolutely correct. It is. I'm sorry, I was reading a comment. Let me put it up here. You are absolutely correct. Outpatient CDI is a whole thing. And they talked a little bit about that. Some lady, well, there was a lady at the she dated herself because she was like, oh my, I guess she's only from her responses, I was led to believe that she has only worked in an inpatient space. And somehow or another, she got wind to something that was happening in outpatient and professional side, and was like, they need our help. I'm like, what? They need our help. She was talking about like the CDI and all kinds of stuff. And I was like, ma'am, please take several seats over there. And then, my favorite came back like, oh, I get it. I see where we're going with this conversation, because no, this has already been going on way before, just because you're now getting wind of what's happening over here on the outpatient and professional side, you think we need you. Ma'am, you can take your cape off. We good. We got it. But anyway, first let me level set, because some people may be like, well, what in the world is a query? And more specifically, what is a leading query? So really, all of this is to say, when you have a question and you need clarification, so you reach back to the provider just to get some additional information. Now, a leading query is not only a request for information, but so there's nothing in the documentation that kind of supports some of the things that that the codes suggest. And so you want to get some more clarification. But you have some information in the documentation, some clinical information that could potentially support. So there are cases where the information, the diagnosis is not there, but the clinical information that is there, or the opposite. So you have a diagnosis, but you don't necessarily have the clinical information spelled out. But there are other elements inside of the record that supports both the diagnosis and the clinical information. And you just need clarification on all of those things. But you're not supposed to direct a provider to a specific diagnosis or procedure. If it is not supported by the clinical indicators, then it will not be a valid diagnosis, even if it's supported in the record. So you just want to get more information. And my understanding when they released this query process was that it was it. But I think when all of these additional questions came up, they kind of walked it back. And so it's not necessarily now the final version. They're taking comments. So if you are working in this space, I also agree with a lot of the folks that have given their opinions on it, that you may want to take a look at it. And if you have comments about something, make sure you submit them. And they let you know through AHiMA and ACDIS how you can do that. But the comments are due by October 25th. So if you have something that you're saying, wait a minute, hold up, this is not even how we practice, or this is something different, or even say this was a great change, thank you very much. Either way, you can do that. But so this whole thing about leading queries and is it prohibited by law? I think the consensus was that it's not a legal thing, but it's more a compliant thing. So what does your policy say? What is your what do your governing organizations and ethics say? And at the end of the day, no, you should not be leading anybody anywhere. You should be making the asking the question to get the information that you need, but not telling them. That's like, and I've heard folks say it all the time, physicians get frustrated and be like, just tell me what I'm supposed to do. No, that's not our job. And so, like I said, it took three conversations, 3 articles, all of this, and it still isn't necessarily settled, if you will. But really just getting the information out. And the one lady, Dr. Reamer, her article, she gave some recommendations, and she says, only give choices which match the clinical indicators. Give all choices which match the clinical indicators. So don't cherry pick. And that's something that, oh my God, used to drive me crazy with auditing or folks who were creating templates for their providers on E&M. They only wanted to give them like what they thought the levels, like level 4 and level 3, 4, and 5. I was like, no, you got to give them all. You can't do that. Don't coerce or give the appearance that you are trying to force the provider into making a specific diagnosis. Never give quality or reimbursement implications in the query. Always give an option for the provider to give an alternative explanation for the clinical indicators, like, quote, other, and then she has a space for them to put that in. Only use, quote, unable to determine, end quote, when that is appropriate. So what was the status of the COVID-19 infection? Did they have COVID-19? Did they have a sequela of a previous infection, or did they not have COVID-19? What would unable to determine mean, and how would a coder code that? So again, these were some of her recommendations related to that. I will mute and let you have at it, sir.
You know, this entire CDI query thing has just gotten out of control for a whole number of reasons. And I think that, and I was listening to you, and I really, really, really understand now what the problem is at a core issue. The core issue is most coders do not know what the clinical indicators are for a lot of conditions. So there needs to be some training for coders, because like the one thing that I drill into my coding students all the time is about congestive heart failure. You never ever ever want to see unspecified congestive heart failure and you don't send a query. There's no reason. I tell them congestive heart failure is always defined by type and acuity. If you don't have both, you need to find out. So, and then to find that out, you need to know, did they have an EKG? I mean, an echo. What is their ejection fraction? Do they have, do they have edema in the lower extremities? Do they have pulmonary edema? That will let you know whether it's left-sided, right-sided. So you can kind of give some information clinically. It's not what you're pulling out of thin air.
Exactly.
And what a lot of providers, especially in outpatient, there's just not enough education, period, because they're so busy chasing diagnoses. That's really what they do. It's just no other way around it. And when you talked earlier about having a diagnosis but no clinical validation, you find that when somebody has been inpatient, they will have a CAT scan. You'll find all kinds of things: a tortuous aorta, and abdominal aortic aneurysm, but it's not addressed inpatient. But then they want to go and send, they want to suggest or suspect. That's what they call it. They want to suspect this condition to the person's PCP, when first of all, you have not even established that that is an acceptable diagnosis.
Right.
And incidental finding, if it's not addressed, is nothing.
Exactly.
So if this provider is going to accept, let's just say it's tortuous aorta, what are you going to do about it? You just can't put in the assessment tortuous aorta. What are you going to do about? How are you going to apply monitoring, evaluation, assessment, or treatment to this condition? Are you going to refer them to a cardiologist? What are you going to do? Now, if you put down tortuous aorta based on, CAT scan from inpatient referring to cardiology, fine. You have evaluated this condition. Then we can code that all day long and you can get credit for it. But if you just want to put down there, tortuous aorta, it's still not clinically validated. So there's a whole lot of education that needs to go on for coders and for providers. And we need to have coders who, because I know I worked with one place where every coder couldn't send a query, only the coding managers. So the person would go to the coding manager and say, this query needs to be sent. And they would send it. Because I've read some queries that some coders have come up with on their own, and they're all over the place. Like they're leading like a mug. Like, So there's not enough education, and then there's not enough enforcement. You have to have people who are not afraid to tell providers, you have to do it this way. And you need to have, in addition to education, you need to have a query escalation policy. and these people don't, you know, I could be on my soapbox all day. I'm gonna stop right here.
Right. And you made some wonderful points. Because you're right. I'm trying to I too have been in situations where the understanding or the procedure for queries involves kind of somebody putting eyes on that query before it goes to that provider, and making sure that it's clear, it's concise, it doesn't lead, and it's getting them to ask the question in the way it needs to be asked, if you will. And to your point, you know, that should stop with the manager. So even if there was some leading from the coder's perspective, somebody else putting their eyes on it kind of says, that's not how we need to do. And then at some point, if they're seeing that, and that there should be a QA on that too, as well, that, you know, hey, we may need to pull everybody in, or particularly a coder who they've seen this is the norm and not the exception. Really provide that education on how to write queries, or don't. Look, look, you got a question, go talk to your manager and let them help craft that query. Go ahead.
What I find a lot of times is the problem with a lot of organizations is they rely on outside provider education instead of providing in-house education. Because when you provide in-house education, that person is going to be there to follow up. They're going to be there to see how effective the training was. Are you seeing an increase? Are you seeing an improvement? When you have outside provider training, they come in for their contracted period. They do a little presentation, then they're off until they have to come back again. There's no kind of monitoring.
And I think the ideal situation would be a combination or collaboration with both, because I've also heard that folks won't listen or pay attention or something internally, so that's why they bring in an outside voice, so they can hear something fresh, hear something new. They could be saying the exact same thing, but because somebody who isn't quote unquote tied to the organization or tied, they think there's no incentive to tell you XYZ, is telling you the exact same thing that, you know, your internal folks are. It's now more valuable. So I see the benefit of both, but to your point, I think there has to be some collaboration with both the internal and the external people to make sure that there is that additional follow-up. There is that that additional piece that goes on after the external consultant has walked away. I know in some of the consulting clients I've had, I ask, so tell me what's happening because I want organization specific material. I want things that are happening, the questions that are being asked, the confusion that is happening here. I can bring you whatever I hear from wherever, but I want this to be part of what you're seeing and what your pain points are, so I can assist you over that hump. And so I always have those conversations like, well, what is happening here? And let's create the scenarios and let's craft the situation. So it's oh, okay, I understand, because this is what I see and what I do every day, not some things that don't necessarily apply. And then, I feel like people take it more to heart if it's something that is with them. And you're right, LaShonda, the vendor does also need to follow up. They need to follow up and or include it in the fee. Exactly. But again, I think that's the collaboration with the internal, because the internal can help you if they're monitoring that, and they again, it needs to be measured. There should be a measure from what happened, where they were before, what happened after they received the education and where they're going from that. So there should be some kind of measure or swing. And if something is awry, then, let's pinpoint, was it the external person? Was it our people? Did we not get it right? What happened? So there should always be that constant communication and dialogue, as well as making sure that the staff is educated. Go ahead. You want to say something?
I have not seen, I agree with LaShanta that the vendor does need to follow up, but I've never seen any vendor follow up, because a lot of times the vendor is a physician and they come in and give very high level talks, and then they're out. So I've never seen a physician-based educator do any kind of follow-up. They just come in, they get in, get out until they have to come back for the next quarter, where they talk about their next topic that they've already prearranged.
So internally, do they then kind of monitor or assess the situation from talk to talk, or no? See, what is the value in that then? I mean,
what they do is they will have, at this one particular company, when the providers had training, sometimes they would let the coders join the training so they would hear it, and then sometimes they wouldn't. So there was no consistency. So sometimes you just know the provider had training, but you don't know exactly on what topic. So there's no way to follow up. And then sometimes they will give you, or they will send the slides out. You could just look at the slides later. But there was no, we're going to start tracking to see if there's an improvement in, let's just say, type 2 diabetes and PVD. Let's say that they were missing that. There was never any concerted tracking where they were going to see an improvement in that diagnosis, or just, an overall improvement in causal relationships with diabetes. I've never seen that.
That's interesting. What LaShanta say here? Now them people not gonna check up on them. That's why the consultants are there. Yeah, it's bananas, and that's why we're in this vicious cycle. And to the point of, why are we still seeing malnutrition as low-lying fruit? I feel like that's a dead horse that's been beaten, but clearly somebody is not doing what they need to do. Oh my God, girl, you just scared. My employer has no compliance plan. Oh, no check on what you asked for. And that's coders and physicians. Bless their whole entire heart. Yeah. Because that's part of what compliance is the monitoring piece, and making sure once the education has occurred, somebody is monitoring that progress and seeing what is happening. Wow. Cool. So that there's more to come, I guess, on this whole leading query, because everybody is back and forth. And of course the attorneys are like, well, if there is no legal precedence for it to happen, then or not to happen, then why is everybody telling you shouldn't? And it's a whole back and forth. It's a mess.
Right, but we also know, people, we had talked earlier about, well, it's not illegal. Well, a leading query is not illegal. It's not illegal, but we know how, if that case does get to go to court, that provider is not going to take the fall if they weren't given an option. If they feel as though they were forced, that's all they got to do is say, well, I wasn't given an option. I was told I could only document this or that. Then there goes your case. Because they're not going to eat it. They're not going to take the fall alone. So I think that, because as a matter of fact, there's even a conversation about where are queries stored, because some people don't put it in the medical record, because the medical record is discoverable. They have it separate outside of the, their health record. You can still access it, but it's not part of when people's records get looked at. Sometimes you don't see the queries, and that's also a matter of policy. You know, like it's queries are they can be very litigious if if the whole process is not handled properly.
Right. And that was also in one of the articles that said pretty much that it leads to fraudulent upcoding. And there is a case versus Kaiser where the government said that, and I'll quote it, Kaiser regularly brought these mind diagnoses to the physician's attention for addition to the patient's medical record using a tool called a, quote, query, which in the healthcare industry is a communication tool used to clarify documentation in the health record. Queries present significant risk for improper diagnosis coding, and national standards guide and limit queries use. The standards include that a query cannot be leading, i.e. cannot direct a provider to a specific diagnosis, and cannot discuss financial impact. But Kaiser routinely violated the national query standards and used queries not to clarify medical records, but instead to press physicians to retrospectively add new diagnoses via addenda that had nothing to do with the visit, so that Kaiser could then seek payment from CMS for these diagnoses. Yeah, that's a whole thing.
And you know that happens everywhere all across the country. Yeah. They all do it.
So it's gonna be interesting. I'm muted. So it's gonna be interesting to see like how the fallout from all of that. It's crazy. It's crazy.
That's a good point, LaShanta. You really have to do your own due diligence.
You do. Because yeah. Things could be read one way, things could be read another. It's like, but what does it say? Read every word in the context of it, because then folks love to pull things out of context too. So you just got to make sure you understand the whole contextual piece behind it as well.
Well, speaking of education, I have a funny story for you real quick. This past week in my class, we were doing reimbursement methodology. So when you have the Optum 360, when you have the Optum ICD-10-CM book for the expert for hospitals, it tells you the HCCs, the CCs, and the MCCs in the tabular index. So, and I picked that book for that reason, because I teach them about HCCs and I teach them how to determine what's an HCC. I also show them how to use the Excel spreadsheet you can get from CMS to punch it in. You can do it, manually or through the spreadsheet. And I also teach them how you can determine whether a CC or an MCC is there and the impact on the MSDRG. Plus, I show them how to manually calculate an MSDRG. So when I was doing it in class, like I could tell they were like, their heads were swimming. So one
I'm sure that's overwhelming.
So one lady who was specifically, she's there from the gate. She wants to go into CDI. So I gave them a question. I said, a multiple choice question, which diagnosis is going to increase the MSDRG the most? So they had the first, you got to code the condition. Then you got to go and see it in the book. If it's a CC or MCC, then make your decision. So she says, do you really have to know this information? So I said, for number one, if you want to get your CCS, it's on the test. So yes, you do. Number two, if you want to work in CDI, how are you going to know if that DRG is right if you don't even know what a CC is versus an MCC and which one is higher and which one is going to impact the DRG? How can you validate a DRG if you don't even know what a CC or MCC is? Because you can't always rely on an encoder. You got to know how to do it. You have to know the theory behind it. Everybody, you can't rely on a machine. You have to understand it.
And I think that's part of our issue, because a lot of folks just rely on the machine and the algorithm that's pushed out through those encoders and think, okay, it spit out to me, this the end all, this the be all, and I'm good. And you're right, you shouldn't.
So, and then I told her, I said, well, when you want to get into CDI, I said, well, let me prepare you. There's also procedures that affect the MSDRG. So once you learn ICD-10 PCS, you have to do the same thing for the procedure. You have to see if that procedure is going to increase the MSDRG and by how much. I said, so it doesn't end. Either you know it or you don't.
And again, that makes you that much more marketable. That makes you having that additional knowledge. It's one thing to be like, okay, I went through a coding program, I know how to code. I was successful with my exam. Now what? You can just get a job and you can start your coding career. But if you want to build on that and you want to be marketable in other areas, you got to know the stuff behind it. You got to know the why. And you got to be able to master that information. Like I said, every year we get these new guidelines, we get this new information that comes out that prepares you for the next year. It's there. They give it to you. It's there. There's no reason why you shouldn't say, okay, I know, because I know in the summer I'm gonna have to do some reading, because this is where all this proposed stuff comes out. Let's see what they're proposing, what they're talking about, and how that will relate to what the final looks like. And then you can do like kind of that comparison and see, well, what are they thinking? What are their thought process and what's happening here? It's amazing. It's amazing. Oh, one thing about the conference that somebody was like the elephant in the room, and it was a couple of elephants, and this was in the House of Delegates room. There's a couple of elephants in the room, but everybody was like, why is nobody talking about ICD-11 in here? And they were not. I'm like, oh my God. They were not. One of the questions I asked, and we talked about the elephant in the room, because this conference was built as a global conference. And they even had the International Association as one of the vendors in the vending space. But folks were talking about how, and my question was, we're here in this room and we are engaged. I get emails from AHiMA on a regular basis, probably 4 or 5 times a week. But you have several people who are credentialed or in our CSAs that don't hear from AHiMA. They may hear from their state association, but they want to hear from you, and they want to see you advocate for them and their jobs and their positions. I understand the global, because we've had these conversations about the opportunities that are out here globally, and that we're gonna be chasing too. But you still got your tried and true person in rural America or urban America, or just in suburban America, that really I'm giving you my money. I'm a member here. I need you to be advocating for my jobs here in the US, not necessarily abroad. And so that opened up a whole different can. Like, yeah, we appreciate the global, the vision, and things are global. But if you're not advocating for the folks right here who are putting the money in your pocket per se right now, or have been, then that feels different. It doesn't feel inclusive, if you will. And then it was like, well, if you look around the room, and I started looking around the room, and the diversity in the room was non-existent, if you will. There were only a few of us in most of these spaces. I did, however, was pleasantly surprised to see a lot of men and a lot of Black men, Black and brown men. So I was like, well, wait a minute, they somebody is hearing this message and coming through. So I was pleasantly surprised to see that. But the overwhelming majority of the folks in most of the spaces, and I think that wasn't an AHiMA thing, because through AHiMA, I saw in their topics and the speakers for their topics, and even on stage, their keynotes, they had a whole plethora of variety. The diversity from AHiMA as it related to that conference was there. They had Alabama State marching band come through there. They bust the whole Alabama State band come through and do their thing. They had a whole gospel choir before Dr. Wylisa spoke. They had a whole gospel choir come in and just almost tear that room up and move folks to tears. They had, and I don't know where the other keynote speaker was from, but she was a brown body, and she came in. She was a physician, and she talked about. She actually mentioned that HI professionals are actually, we're the white coats. We are the white coats for real. And she, talked about how folks had helped her in her career from the health information lens to understand, what it was. She was like, it was really just eye-opening to have the conversation, to talk about and get to know, like we know what we were taught and trained on in medicine, but marrying the two together and hearing this other perspective was eye-opening for her. And so she advocates to other providers to have that conversation or listen to other providers who've had, so you can get a better understanding that we're really all in this together, and working collaboratively will benefit everybody, and ultimately our patients that we're trying to help. There was another gentleman. There was a Black male keynote speaker. One of my friends was like, I don't get the connection, but he was up there. So so they tried, I think, in the presentation of diversity, actually do that. But yeah, those were some of the elephants that were actually in the room. Go ahead.
No, I'm good.
Okay. You look like you wanted to. you look like, okay. I'm muted over here. You look like you wanted to pounce, so I was gonna let you. I was gonna let you jump in. Cool. So yeah, those are all the things. Be on the lookout. Like I said, I believe there's more to come as it relates to this whole query thing, especially since they are taking comments. LaShanta, please, you said you got some comments. Make sure do that. Let your voice be heard. If there's anybody else who have comments after reading that information, I'm going to put it in I'll post it. I will post it I'll go back right now. Well, after I shut all this down, I'll post it on YouTube. I'll post it on the YouTube description so you can see it there. And I'll put the articles there too. I'll do that as soon as we drop down or drop off. So I'm sure there will be some additional buzz. And then even when it drops, or the final, I'm sure there will be some additional conversation had about that as well. Did you want to have any additional final thoughts, Mr. Jesse?
This was a very good discussion as always. I mean, I was really excited because I wanted to hear exactly what was discussed. And I'm glad that, AHiMA is really starting to step up, and I hope they take a larger, role moving forward. And I'm glad that they're talking about other opportunities, so.
And that was one of the things that they were saying, they want folks to know that AHiMA is here. We've been here and we are here, and folks better. And here's a quote from Lauren Ripplinger, and she is she's an attorney with the advocacy piece, and it was like, folks better watch out because AHiMA is coming. So they were putting folks on notice all over the place, letting them know, we're not only are we going to be sitting at these tables, we may be creating some tables and inviting others. So just know that we are here. We are here. We are AHiMA. We are the health. We are the heart of it all. I said that for Ohio, but we are the heart of it all. Even in this revenue cycle. So I agree. I think this was great. I'm still excited. I'm still wore out, but I'm still excited. It always gives you that additional charge, if you will, coming from the conference, even though, I side eye providers when they come back, because then they want to tell me all this stuff. And I'll be like, that ain't right. Who told you that? Especially when it relates to documentation or coding or whatever. I'll be like, really?
I do want to mention, well, you had mentioned earlier about how people have options in terms of certifications. And, that is really a key point, because I know for me, like I make sure, like, there's certain credentials I have no intention on ever getting, because I already pay enough. I'm already a part of 2 organizations. I don't need to join a third just for 1 credential. Like, it's just not even worth it. And I try to pick credentials that are in the same organization. So I just have to maybe just increase the CEUs, but I don't have to. It's not like it's a whole separate set of requirements and a whole separate, end date, recertification date. Because it gets to be a lot. It gets to be expensive and time consuming.
Very expensive, particularly if you don't have an employer that, and that used to be a perk, that used to be part of the reimbursement package, but nowadays it's not as much. And so you are individually responsible for that. And I agree. That's why, because I started my journey in the AHiMA space and learning, AHiMA, going through their program. But once I got into coding, I understood that there were the 2 kind of buckets, and I felt AHiMA at the time was geared primarily towards inpatient. They were branching slowly into some professional and outpatient, but their bread and butter, the thing that they have been known for all of these 100 or so years, was inpatient. And so with AAPC coming along and focusing more on the professional and the provider, that piqued me as well. So I always made sure I have 2 feet in both areas, which is one of the reasons why I don't necessarily I know folks like the certification of one or the other as far as education. I want it to be broad enough that you can go either way, and no one is leading you one way or the other. So I provide that broad kind of level set for anyone interested in either the inpatient or outpatient, but primarily just a good foundation, period, a good coding foundation, period. And then as you kind of determine based on that which way you want to go, then I lead you along those appropriate paths. But yeah, because that's a whole other conversation. But yeah, so
and it's so funny you should say that, because so many nurses, because see, nursing is different. Once you get your license, you can go into any kind of area you want to, if you have experience or they're willing to train you. You don't have to. You can get a certification to specialize in it once you're in it, but you don't have to have it to get into it. So that's what's different with coding, because coding, you kind of need a credential to get into coding. But then, so people is very different how I have to explain transitioning into coding to nurses, because nurses are so focused on, well, a license and you have to have this and then you go do that. So I try to get them, well, do you know if you want to work inpatient or outpatient? Because that is like the major, dividing line. You want to work inpatient or outpatient.
That's right.
And sometimes they don't know. So I have a video that I always send everybody that describes all of the major credentials and which codes that you need to have. And I just tell them, do your research, because you don't want to, when you have clinical experience, it's best to capitalize on that experience, regardless of what it is, whether it's maternity, pediatrics, ambulatory surgery. You want to capitalize on it so you can make some inroads, so you can make some money, because you have a skill set that you can monetize in a new way. So it's explaining that to them and just getting them to realize that you have to pick a lane almost. Whereas in nursing, you don't have to. You can pick a lane whenever you decide to. But in coding, you have to really pick a lane and then get into it. Then if you want to deviate, then you got to prepare yourself with the proper certification to get into that lane. So it's a little different, and it kind of spooks some people out.
Yeah, I agree. but it definitely, to your point, you need to know where you want to go.
Right.
It'll make your life a little easier, and you won't be spinning like, well, what is this and where is that, and then stopping and starting and all of that. Yeah.
We have somebody wants to come to the stage, so let me.
Okay.
Do we invite to speak? All right. Welcome, MT.
Good morning. Thank you for allowing me to come up on the space. Can you guys hear me?
You're kind of low.
Can you? Hello? Oh,
Much better, much better. Go ahead.
Okay, yeah, because I just paid my phone bill, so I ain't know. But I'm a nurse as well, and I'm very curious, especially Jesse, to hear your perspective. But you guys had mentioned these certifications, and the questions that I had is like, what's the big difference between the two? Not just like inpatient and outpatient, but like as in terms of like the quality of the work that one has to do, as well as the income potential. I'm curious about that.
Clarice, I'll let you go first.
That's a mouthful. Look, that's a whole other session. Well, all of them, you as far as the quality of work, they're all have professionalism and ethics around all of them. And so making sure that you meet that level is should always be the goal and the aim. It really depends. The various certification depends on the specialty area in which you want to work. Like, and not just outpatient, inpatient, but like CDI, which is the clinical documentation integrity. And so the role and the functions of that position and credential is different from just a I won't say a regular everyday coder, but I mean a regular everyday coder. Because there are more things that there's a higher level knowledge base that you must have in order to complete that task. Oftentimes people come from either coding or nursing to get in that because they understand the clinical pieces behind that. It's very, very, it's much more clinical than your coding credential. You're living and breathing into that documentation to find those clinical indicators and parameters to assist in validating, if you will, the documentation from the provider and the diagnosis and or procedures that the provider did. So oftentimes coding and in you all cases, nursing is kind of the stepping stone to get into that part of it. You have compliance credentials that come out of AHiMA. You have compliance credentials that come out of other organizations, again, built on wherever it is you're landing in health information. So just health information in general have different pathways that you can go through, and depending on the pathway that you follow, usually there's a credential at the end of that. And so if you like IT, if you like the privacy and security, there are credentials around those things. Just making sure you know what it is that you have a passion for or that you're interested in, and then following that pathway, and then understanding what's required for that credential, and making sure that you have those things tied up in a nice little bow in order to get that credential. Mr. Jesse, I'll let you.
That was very well said. And I think that the only thing I would add to it is, like Clarice was saying, you have to know what it is you want to get into, because it's not like nursing. Whereas in nursing, you might be in med surge, but you might be pulled to a cardiac floor just for a shift. Then you go back to your floor, even though cardiology is different than working in your regular, ICU unit. There's still a lot of overlap. But in in HIM, there are some areas where there's no overlap. There's some, but it's very highly specialized. So for instance, if you want to go into CDI, you have to know coding, but you don't have to be a coder. But you need to know how to code. You need to know the coding guidelines. You also need to know more than, well, you have to think differently than just a regular production coder, because your job is very specialized. You're trying to connect the dots. You're trying to improve documentation. You're trying to tie up all loose ends. You're trying to make sure that at the end of the day, you're never supposed to make it about money, but at the end of the day, it's about so your hospital can keep all their money, and your case mix index is reflective of what is actually going on in the hospital. And if you wanted to go into CDI, if you like data analytics, if you like programming, if you like she said, IT, if you want to go into privacy and security, and all of these areas, you had the potential to make six figures without any hesitation. So I hope that answered your question.
Yes, and I also have another question. What would be a good entry position? Like, in what area would be a good entry position to get one's feet wet? I mean, I'm assuming we need the or you guys mentioned we need the certification in order to do the job, of course. But after obtaining the certification, what would be a good entry level position to just kind of experience it, so that we kind of even get a better idea of how the other certifications or specialties would be like?
It depends on your certification. Like, you can't, like, if you have a CDI, if you get a CDIP credential, you can't compare that to healthcare privacy and security, because it's not the same. It's totally different areas of responsibility. Or you couldn't compare that to auditing, because it's not auditing. Auditing, they're very specialized skills. I'll let you come in, Clarice.
So, MT, is there a specific area that interests you?
CDI, because I heard that six-figure mark, but not necessarily, because I really don't know much about coding at all. So I just entered this room so that I can learn and just hear from your other brains exactly what it's about.
Well, you can get six figures and I'll use your term, and thank you, Mr. Jesse, for the production coder. You can get six figures there as well. So there are opportunities all around in all of those areas. Again, I would just recommend that. Good morning, Dr. Lisa. I would recommend that you kind of just do some self-reflection and determine, because then you're going to be chasing paper, and this is not a chase paper type of profession. You build. So you start with the foundation. So if it's coding, if it's compliance, if whatever it is, you start with that foundation and you build upon that. And as you build, of course, the paper comes, but you're not necessarily chasing the paper. You're chasing the information to get you to the higher level in which the higher paper comes, if that makes sense at all. If you're chasing the paper, if you will, it's like it's like the carrot and the stick. I mean, it's like it's like somebody with ADHD, and I don't mean to mention, belittle anybody with ADHD, but how you shift all the time. Like, oh, I'm doing this. Oh, wait, this is here. Oh, wait, this is here. It's too much, because this is a lifelong learning profession. It's too much to have to absorb. It's too much to have to manage and maintain in order to do that. So you really want to find like the area that you're passionate about, the area that you really want to learn more about and be comfortable with, not only learning more, but the change that happens in our profession. In all of those areas, there are changes that happen all the time, which could frustrate a lot of people. But if you're passionate about it, if it's something that you want to do, the change, the change is coming, and it won't bother you as much, but you'll either you'll either be proactive or reactive. And if you're passionate about it, 9 times out of 10, you're going to be more proactive. And so you're looking to see where the changes could potentially come versus trying to chase it. Again, if you're chasing the money or chasing the paper, I don't think that's the appropriate approach to go. For me, go ahead, Mr. Justin.
I wanted to echo that same point because we talked earlier about data analytics, and I was like, I really wish I was saying that I really wished I liked it a lot more than I actually did or do, because what made me first think about it is I had an agency contract as an auditor, and I was telling my recruiter that I was thinking about getting into data analytics, and he was like, "Oh, well, if you can get into it, I can easily get you $70 an hour on a contract." Now that's some pretty good money. I'm like, "Oh, wow!" But then, like Clarice said, you can't chase paper. You have to. It's about a skill. Is this something you like to do? Because you have to master it, and you only master it by putting time in. And if you don't like it, you're not going to put the time in. And I really realized when I started looking into it and tried to study, I'm like, this is not me. So I found that I like CDI a lot better. And even though you can get CDI contracts, they're not like, I'm not going to say that you can get $70, but that's really not like typical, but it's not too far from it. But you can still make a decent living, is what I'm saying. And you want to be happy. You want to be satisfied with whatever it is you do for 8+ hours a day, 5 days a week.
Completely understood. And yeah, I know I mentioned the 6 figures, and I'm not a paper chaser. But I have come to this period in my life in which I understand whatever work, because I don't believe in working harder than I have to, but I will work hard. But from what you guys are explaining, it's definitely about a passion more than it is about chasing money. And I'm not a chasing money, but how do we find out, which of these certifications we are like? I want to know, how can we find out more about this job? Like, before I went into nursing, I wish I knew more what like nursing was actually about. So are there any resources that you can recommend that would kind of give an insight into more about what each job entails?
Go ahead.
Absolutely. I think that you first start by going to the sources. So you can go to ahima.org and you can go to aapc.com. Those two websites, because those are the two titans in the industry, they will give you all the information you need to know about each credential, what it entails, what you need to know, and what kind of um, employment opportunities you can have as a result of obtaining that credential. Then what you also want to do is you also want to do your due diligence, and you want to go to, I always tell everybody, go to Indeed and just put in the credential that you're interested in and see what comes up in terms of opportunity, see what comes up in terms of job description and even money. And then once you are satisfied, then you find a program that will help you achieve your goals.
Understood. Thank you very much for this information.
You're welcome. Glad we were able to assist. And I didn't have anything else to add, Mr. Jesse. You hit it. Hit it out the park.
And thanks for coming to the stage.
Thanks for coming to the stage. We appreciate that.
Thank you.
Okay, so I think we spilled and overflowed. And Dr. Lisa said, trust but verify. You are absolutely correct. That is true. Make sure you and the other thing, reach out to connect with folks, network. There are people here in this room that will be able to assist you or ask questions. Feel free to reach out to one of us. We will definitely provide you some additional information or resources that you need that'll help you along the way. Talking to others who have kind of led the way or created their own path, because I feel like I've created my own path in a lot of ways. You create your own path. Just talking to folks to get a better understanding of, what a day in the life looks like for them in the position that they have. And if that's something that, like you said, you wish somebody would have told you more about nursing, just have those conversations. There's plenty of us out here who would love to, help guide you in deciding where it is that you want to land. So yeah, just reach out and just continue to network, and always keep coming back here. We got all kinds of stuff that we talk about that'll assist you in that process. Mr. Jesse, did you want to add?
No, you covered it all. Like, that's it. Like, that's why we're here every Saturday to answer questions and to help people, because I mean, HIM is a wonderful field. It's a wonderful industry. And it's just as broad as nursing. You can find your lane. If you can't find your lane in HIM, it doesn't exist.
Yeah, it's so much out here. It's so much out here. It's remarkable. I wish more people knew about us. And that was another thing that, see, I'm going way over time. That was one more thing that they talked about, that they can't find people for the jobs, and we're gonna touch more on that next week. How about that? I'll leave that at that, because I was like shocked, and they were, just to hear the battles back and forth, like, well, what? But we'll talk more about that next week. And I'm also going to try to reach out to a couple of the people. So Dr. Lisa, I'll be coming for you. Reach out to a couple of people who actually attended, that I have had some conversations with, and maybe just get some of their insights. I may either try to put together kind of a panel, and do a recording that we can play here, snippets of it here, or even actually have it here. I'm still in the process of that. And then, did you get my email about the end of the month, sir? You're muted.
Yes.
Okay. So look for.
But we got to
we'll
chat
talk about that. Okay. More like a seminar today. It was, wasn't it? It was. I felt seminar-ish. But thank you all for joining us. If this information was valuable for you, help us share this message by liking the video, sharing the video, and subscribing to our channels, the Professional Reimbursement Network. You can also check out Mr. Jesse at his channel, The Coding Nurse, which is also on YouTube. You can also, if you're in the room, join the Clubhouse. Click the little green house so you be part of the club and you get information about what's happening here. Like I said, in the club network, I believe I'm probably following everybody that's in the room. Follow each other, have those conversations. Like to MT's point, there are not a whole lot of coding rooms out there on Clubhouse. So we try to provide that information. And then as we have expanded not only to our Clubhouse family, but also Facebook, YouTube, and LinkedIn. So you can check us out. And if you want to see it, those are the other areas that you can actually see the broadcast. So this was great. I'm so glad you are here. Sharing is caring. So share this information with others. They need to know that they have a voice, and they definitely have a voice here, so they can join us and join in on the conversation. So again, this has been great. Thank you all for joining us. And remember, be safe, be kind, and don't wish for it, work for it. Until next time, take care. We're generally here Eastern Standard Time, 9 a.m. On Saturdays. So take care and have a great rest of your weekend.